And welcome to the 2024 SickKids National Pain Awareness Week Speaker Series. Thank you for joining us today. My name is Harvey. I'm one of the clinical nurse specialists on the acute pain service here at SickKids, and I'm going to be the facilitator for the session today. I always like to just mention that today's session is going to be recorded and it will be available for viewing for those who request access. We appreciate that the timing of our speaker series is not necessarily accessible for all staff, especially those who are currently providing frontline care to patients and their families. So we're hoping that by recording these sessions, we're improving access to education for all clinicians. We do ask that during the question and answer period at the end of the session, if you can please just not disclose any confidential patient information, that would be great. So this is the second year that we have put on a speaker series event like this. And we're hoping to reach many SickKids staff, trainees, and students, as well as people from outside of SickKids. And you're going to see on your screen that there is a schedule of the remaining events planned for this week. And we encourage you to use the QR codes while they're up there and register for any events you're interested in attending for tomorrow, Friday. The other thing I would always like to add is if you feel comfortable, not mandatory, but if you feel comfortable introducing yourself in the chat and just letting us know where you're from, so what your role is, and what organization you're from, that would be awesome. Before I introduce our speakers and topic for today, I would first like to acknowledge the land on which SickKids operates. For thousands of years, it has been the traditional land of the Huron, Wendat, and Toon First Nations, the Seneca, and most recently the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. SickKids is committed to working toward new relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land in caring for children and their families. So it's my pleasure today to introduce our guest speakers for today, Tait and Lucy Burton. Caleb has been a child life specialist at SickKids since 2017 and has covered many of the outpatient and procedural areas of the hospital. He now mainly works in phlebotomy and peri-operative services. Caleb is passionate about helping patients cope with stressful, scary, and potentially painful procedures. With motivation to find the right way to do the tough thing, he strives to help achieve the best possible health outcomes for patients, families, and the healthcare team. Thank you for joining us today, Caleb. And Lucy currently serves as a certified child life specialist at McMaster Children's Hospital in the pediatric medicine unit. She holds a Master of Science in Child Life and Pediatric Psychosocial Care from McMaster University. Lucy completed 2 clinical internships, the first at SickKids, focusing on child life support and perioperative care, phlebotomy, and the general surgery inpatient unit, and the second at Grand River Hospital in the oncology satellite clinic. Prior to her role at McMaster Children's, Lucy spent a year and a half at the Hospital for Sick Children, where she supported outpatient clinics and later served as the certified child life specialist for the orthopedic surgery and otolaryngology ENT inpatient unit. Without further ado, welcome Caleb and Lucy. Liz is in the background and is kindly going to share their slides.
All right, so Ashley did the introductions there, so we don't have to do that one, but Lucy and I today are going to be talking about child life strategies to help children through potentially painful, difficult, or stressful procedures.
Yeah, so this is sort of our overarching definition of what child life specialists do, just in case anyone is unfamiliar. So our ultimate goal is really to reduce fear, anxiety, and pain for patients and families coming into the hospital environment and to enhance coping. So we really want to take kind of that holistic biopsychosocial approach to healthcare. And so when a child is coming in for a potentially stressful or painful procedure, we're really assessing and considering all of those factors that the child is entering the environment with. So maybe past healthcare experiences, past painful procedures that they might have had, their developmental level versus their chronological age, family dynamics, siblings, the child's comorbidities or other diagnoses that they may have had. So these are all things that we want to consider when implementing therapeutic interventions. But another big part of our job is also to make the clinician's job easier. So part of the focus on our presentation today is really like equipping clinicians with kind of those quick and easy child life tools that we implement and that are fundamental to our practice that you can utilize in your own practice to support patients when child life may not be there. So that'll be more of our focus today.
So we have some of our child life goals here. This is not an all-encompassing list by any means, but when Lucy and I were putting this together, they were some of the things that we wanted to make sure people knew, but that we feel most strongly about and are kind of when we put our best foot forward, these are the main things we're looking at. So it's providing developmentally appropriate education about illness, procedures, about hospitalization. We strive to minimize stress, fear, and anxiety and promote coping. And we really want to stress the minimizing there because it's about trying to help cope with these. It's not that these strategies are going to eliminate it completely, but we want to do our best to minimize and manage things as best possible for the patients and families. We want to optimize normal growth and development, and a big part of our job is to use play as a tool for assessing responses as well as education and a lot of our other goals. And we promote a holistic family-centered model of care. And I think that's a huge part of the SickKids approach as well. And it's to help advocate for children to participate in their decision-making. We want to communicate the needs of patients and families to the healthcare team to create those best outcomes that we possibly can.
Okay, so I really like to start with these slides because obviously a huge part of our education is on child development. And I think that these developmental considerations are really important to know about when we're thinking about what might exacerbate that pain or how these things might influence procedures. So we won't have to go through everything, but if we just want to focus on kind of those hospitalization issues and interventions, those can be really helpful. So if we're thinking about kind of infant and toddler 1 to 3, they're in that sensory motor stage of development. Attachment is very important at this age. So when we're thinking about going into a painful procedure, we really want to emphasize supporting the parent and the caregiver and that primary attachment figure for the child. They can have difficulty with separation. So ensuring in the procedure, how can we incorporate the comfort of that caregiver and maximize their involvement? And also that sensory stimulation. So is there anything that we can do in the clinical environment that you're in to kind of normalize that environment for that infant or toddler? So creating something more soothing, something like putting on music, engaging them in a little bit of play, something just to enhance their coping that way. Preschool age, so 3 to 6, so the pre-operational thinking stage of development. So here we see a lot of magical thinking, right? So a child might enter a procedure and have a lot of misconceptions about what's going to happen, and they have large imaginations. So it's really important to be able to educate them in a really developmentally appropriate way. And as child life specialists, we often will use medical play, but this is something that you can do as clinicians too, just by showing that child the equipment, explaining in really simple terms what's going to happen can be really beneficial for this population because they might come in already heightened with an idea of what's going to happen. And so educating them that way is really vital at this age. And also distraction can be really useful for this population as well. So finding out if there's anything that you can do to help distract these younger ones, that can be really effective as well. School age 6 to 12, so more concrete operational thinkers. These are the kids that might more explicitly express their fear of pain. You get a lot of questions about pain at this age. How much pain will I experience? Maybe they come in already having an idea of how much pain they'll experience. And so again, you really want to prepare this population and ensure that they know what's going on. Obviously, at this age, you can be a little bit more conversational, still keeping it developmentally appropriate, and teaching some of those more planned coping strategies to encourage mastery. And we'll kind of go through some of the details of that later, but definitely beneficial for this population as well. And then adolescence, so about 13 to 18, formal operational stage of development. So again, you might get, more explicit fear of bodily injury, of pain. I like this example here because a lot of teens will ask about this when they're going into the OR about, their level of awareness during anesthesia, waking up from surgery, things like that. And you might get, some maladaptive responses with anxiety, depression. So really checking in with this population, communicating very honestly about what's going to happen, building that trust with them that way, and a lot of preparation as well as like debriefing and follow-up discussion, finding out what worked best for them and ensuring that their opinions are heard and that they have as much choice as possible in what's happening. So I really like this slide just to go back and imagine that you are the patient and kind of take yourself back to your own childhood, not knowing, it might be that child's first time coming in and having a procedure. Maybe if they're coming in for an injection or a poke, they've had many bad experiences with pokes. You're not sure how long you'll be waiting, how long it will take. You just don't know how that child is feeling entering the environment. And we know that all of these factors can lead to feeling, vulnerable, powerless, anxious in the hospital environment. And it may present as externalizing or internalizing behaviors. And often for kids, you can see very opposite behaviors to how they usually may act in the community. So a child that's typically shyer or who doesn't vocalize as much might be crying, yelling, exhibit those externalizing behaviors during the procedure. Whereas, the opposite, a child who's really social, outgoing, usually expresses how they're feeling, might appear more withdrawn, a little bit more of a flatter affect. So just being mindful of what's kind of influencing that and how we can best prepare the child for the procedure ahead.
So next, we're going to talk about some of the guiding principles to support your patients. We know that every child is an individual, and we want to make sure that we're focused on that child in that moment the best we can. But we picked these principles because no matter the age, developmental level, previous experience, anything like that, some aspect of this can be really helpful when supporting in the preparation, in the support during, as well as after. So patient and family-centered care, making sure we're including the patients and families as best possible. And a huge thing is honesty, making sure that what you're saying is true. It doesn't mean it has to be every single aspect of what's happening, but making sure that with what you're saying, it's going to match up with what happens. Being able to offer realistic choices within reason, and that's a huge part of that patient and family-centered care. But as the healthcare provider, to not only make sure you're taking the chance to have those options and those choices, but that they can know what those are and working together collaboratively to put those in place. Developmentally appropriate language is a huge one for all ages, all stages, everything like that, because if you're trying to talk someone through something, you want to make sure it's in a way that they can understand. And you're focusing on what's going to happen and why. And sometimes, at different developmental levels, those things can be really, really simple. But again, we want to make sure that they're true, and we want to make sure that they're appropriate so people can understand them. You want to consider the environmental factors where you are, because like Lucy said, you're coming into this new space, you're coming there, being able to control the environment as best possible, being able to make sure that it's as comforting or best suited towards what's going to happen next is a huge aspect. Sometimes it can be as simple as bringing a warm blanket when you're somewhere, or making sure if someone's sitting on a bed that it's sitting up at a comfortable spot. Those ones can be simple things that can make a huge difference. So we wanted to talk about preparing for a painful procedure, and then we're also going to talk about supporting during. So to go along with those guiding principles, you want to make sure that you're providing simple, honest explanation, but also that there's opportunities for questions. I think sometimes people, when they're going to talk about something that can be stressful or painful, it's a difficult thing to talk about. And you get worried about having this, made up paragraph that has every little thing in it. But what can be most important, and I think most helpful, is you start with something simple and honest, and you allow a chance for questions to come further. If we were going to talk about an NG tube, for lots of different ages, you can say that we have to put this tube in our nose and we're going to help you do that, and it will stay there while it helps with blank. That's the what and the why, but making sure that the child can ask questions. We want to focus on the sensory factors of the procedure and of the patient's environment. So you're going to talk about what it may feel like. You want to make sure that those are true things you're saying, but also not catastrophizing. For an NG tube, if someone asks if it's going to hurt, I usually say it wouldn't necessarily be something that could be painful, but it can be unpleasant or uncomfortable. And here are the things that we can do to help, or here's how long it may take to work. When using child-friendly language to explain procedures, there's some great words that really help for everything, to explain, to help, to make better, to look at all ages, whether you are 2 or you are 17, those match up. And for lots of kids, it's great for them to be able to know that. But again, with that opportunity for more questions, you're able to build on it as they go. And when they ask questions and you have that back and forth conversation, that's the way where you might be able to understand some of the misconceptions that patients may have. So throughout all of these conversations and preparation, if you're making sure you're paying attention to the patient to see that, are they understanding this? Should I ask them if I should explain it in another way so it can make more sense? And one of the things that can be really helpful too, if you have the time and preparation, is get the child to explain it to someone else. Because with that explanation to someone else, you can see how much they understood and digested, and see if there's anything we need to clear up. And again, with the what and why, we want to make sure that kids are understanding what we're doing for them as opposed to them. So instead of just thinking that we want to do these things because it's what we want to do, if they understand at the level that's right for them, why we're doing the things, what it is, and we're honest with those as well, it helps them prepare. But also when you look back at the experience as a whole, that level of understanding means that there was a lot less misconception, confusion, which can be something that can have long-term lasting effects, positively or negatively, whichever way we're working as far as those types of conversations go.
For offering realistic choices, So I think, choice and control is so important to kids at any age, and rightfully so. If the procedure is happening to their body, then we want to offer those choices within reason, right? So, for example, if we look at blood work, for example, if the child is like, I want it to last 1 minute, like, that's not necessarily a choice that they can make, or if they're like, I want to sit on my own, and then they're running towards the door before the procedure can start, that's not a realistic choice for them to make, right? But if we can think about what choices we can offer them, there's a lot of different options for different procedures. So blood work, for example, you could offer, do you want to sit on a parent's lap? Or do you want to lie down? Do you want to look or do you want to look away? Do you want to watch your iPad for some distraction? Or do you want to squeeze, your caregiver's hand? Do you want numbing cream or cold spray, right? So just thinking about all of those little choices that you can give for different procedures that are realistic and that you can follow through on. That's really important as well, is to have that follow through. So if you're going to introduce those choices to that child, they're going to remember for sure. And if you're not abiding by those choices during the procedure, right? So that's really important. Do encourage comfort items and strategies as needed. So it's always helpful to kind of see what the child brought with them. If they brought a stuffy or they have a jacket with them, you can always offer that. Do you want something to squeeze during this procedure? Some kids find it really helpful to squeeze onto something during. If they seem really attached to their caregiver and they want to be present, how can you incorporate that support during the procedure? Offering, if you do have any like quick grab kind of distraction items for them that you can use, or seeing what they have with them. If they have a tablet or something, then making sure you try and set that up for them if that's something that they want to do. And, if you ask them like what has helped or not helped in the past, that can sometimes be helpful. But also if kids aren't giving you answers for some of the strategies that they want to use, sometimes it's really helpful to say, I can tell you what some other kids have wondered or worried about, or what some other kids have used during these stressful procedures. Do you want me to tell you about those and see if we can come up with a plan for something that works for you, right? So it's something that doesn't take a lot of time, but that can be really valuable for the child beforehand. So preparing for a painful procedure, these are kind of the best to avoids that we like to put in there. So I think a lot of us know that around children, you want to avoid a lot of medical jargon if you can, right? And, using that child-friendly language. And, in child life, a lot of us have like our go-to phrases that we kind of use with kids, because you still want them to be honest as well, right? So, instead of a needle, we might say poke. Instead of anesthesia, we might say sleeping medicine. But I also like to name the actual word before giving the other word sometimes too, right? So you want to say anesthesia or sleeping medicine, because they're going to be hearing that word likely from other clinicians as well. So that can be helpful. And you also want to explain the sensory experience or the function kind of the procedure that you're doing. So when in doubt, if you can't really think of like a code word that the child might understand, if you're looking at like an NG tube, instead of, just saying an NG tube with the assumption that the child might know what that is, you could say like a tube that goes into your nose to deliver feeds and medicine to your tummy, right? And still call it an NG tube. And then that child just has that little explanation. And from there, questions are more likely to come up rather than just asking them, do you know what an NG tube is, right? So giving them that little explanation first is more effective. And then best to avoid only speaking to the parents about what will happen. So that's just sort of a bedside manner thing too, right? So when you're coming in, if that procedure is being done on that child, I often like to address them first. And if you can get on their level, that can be really nice too. I know I had a patient in halo traction previously who was in a wheelchair and couldn't move her head at all. And I said to her, can you tell me something that you really like about the hospital, and can you tell me something that you find really tricky? And she said, well, no one talks directly to me. Like people would enter the room and address her, but she couldn't see their face. And that was something that everyone, she felt like, was doing. And that mattered so much to that child. So these are really simple things, but being able to address that child directly and in a developmentally appropriate way, you're going to build a lot of rapport and trust that way before this potentially stressful procedure starts, and a kid is going to find that really valuable.
We also want to avoid making unrealistic promises to patients or misleading them. And that can be about how long something's going to take. That can be what it will feel like. We want to set proper expectations for the children and of the children. So don't say it's going to be 2 minutes if it's going to take longer. Don't tell them it's not going to feel like anything if it is. Even when, talking about numbing cream or something like that, it means you feel less. It turns it from a pinch to a push, but making sure that they have a proper understanding of what's going on, because a huge part of the preparation is making sure we're taking away surprises. So if we prepare, but not in a way that's actually going to happen, we're not taking away that surprise, which is a big thing of what we're trying to do. Misleading the patient can be a big one as far as distraction as well. I think distraction is something that is a choice, not a trick. If you're someone who is looking away for something, or if we were doing a catheter insertion, do you want us to, put something in between so you don't see it? It's not to trick you that it's not happening. Or if a kid asks what something is, say, don't worry, watch the show and then keep going. You want to make sure that we're building that trust, because that not only helps for that procedure, but in the long-term healthcare. We know that if we don't properly manage the trust between healthcare providers, patient, and family, it creates a lot of hardships down the line. So we want to make sure that the promises we make are ones we can keep, and that we're telling the truth all the way through. I also want to put it out to both parents and providers to don't worry about the exact right way to say things. I think that's where people can get really stuck up, and actually stops us from having those types of conversations where there's, if I were to word this next time, I'd say it differently, is a lot different than saying the wrong thing. So I think if you've said something to a child and it doesn't appear to come across the wrong way, say, you know what, that seemed to upset you more than I thought it would. Do you have any questions, or can I help that make more sense? I think taking a little bit of that pressure off yourself really helps those conversations flow naturally. And that's when we're going to be able to have the most success with these types of conversations.
Do respect the request of the child within reason. So this is kind of that follow through piece again as well. But just thinking about during a procedure, whether or not you're able to follow through with that request. So for example, I find sometimes when procedures are particularly stressful, the team or the family or everyone can actually start over talking, right? For the child. It's okay. Everything's good. Okay, we're almost done. Here we go. And there's a lot of voices happening at once. And I've seen more than once kids kind of say, like, it's too much talking, right? So if we think about that, that's something that we can respect, right? So they're saying, like, for me, this is overstimulating right now. And, can we ensure that we're using like a one voice approach, for example? So if mom's appearing to be that really comforting coach, is that something that we can ensure? And that's something as, clinicians that we can advocate for in that space if it's appropriate as well, right? And also, if you say that you're going to count down prior to the poke and you make that plan with the child, then following through with that too, right? And just those small steps that you do beforehand, ensuring that their preferred distraction is in sight line. So making sure that what you plan for is in access and things like that. Do encourage the child's job during a procedure. So this again is that kind of control piece. Kids respond really well to having that job discussed beforehand. And it's also an easy way for you to go back and kind of implement those coping strategies. So the job that we kind of go back to for pokes often is your job is to stay really, really still and take those deep breaths. Keep your body still and take a breath. So even practicing that with the child really quickly beforehand, and then throughout the procedure, kind of going back to that and saying, okay, are you taking those deep breaths that we've practiced? Can you do one for me now? And then it's also a nice way to reinforce what they did well following the procedure, right? So that positive reinforcement of specifically what was done well, rather than, great job overall, you're a rock star, things that those kids hear, because for them, maybe it was a really stressful, hard experience. And so that's almost invalidating rather than validating specifically what they did well and what they can carry with them for the next procedure. So, you did really, really well keeping your body still. I know that was really tricky. And when your body's really scared, it's hard to keep still. And you did a really good job of that. So things like that, kids can respond well to as well. Do assess caregiver involvement as needed. So I would say this is just, making sure, again, that holistic approach that the family is involved. If that's needed, if you're going to go into like comfort positioning, which Caleb will talk about later, ensuring, if that parent has helped that child or done a bear hug or something for that procedure before, ensuring that they're involved again, asking the parent, what worked for you last time and what didn't help? What did you observe with your child that you found was really helpful for stressful procedures, and how can we implement that? Getting their perspective as well can be really valuable.
We want to make sure that we're using helpful, child-friendly phrases throughout the procedure to encourage coping. A lot of that comes to, if you've made a plan before, being able to come back to those, like Lucy said. If it was holding someone's hand, if it was taking those breaths, those things that we can help. And, sometimes when everything's going on, being able to make it nice and simple and saying, I'm right here with you, mom's right with you, dad's with you, whoever may be, caregivers right here with you. Let's take those breaths. Let's do this. And instead of it always having to be, the idea of child-friendly is this big, bubbly, out there thing. It can be that simple, that nurturing side too. And being able to know that if our plan or our coping strategies might deviate, that we haven't been squeezing the ball, taking the breaths, staying still, that we can always come back to them. It's not like if you stop taking deep breaths, we can't start again at that moment. And, making sure to say, if it's helpful for a child and they know the steps, for an IV saying, okay, the needle's gone, but the straw's right here, so we have to stay nice and still. So those things that might be able to help them know what steps next, especially if you've done some of that preparation. And if through those phrases, you're able to keep them informed of what's going on, but also come back to, people are here to help you. You're safe. I know this is hard. You're safe right now. We're doing everything we can. You're doing a great job staying still. We also want to make sure that that plan is communicated to everyone in the room as possible, and that like Lucy was saying, prior experience is known. If we know that a patient wants it nice and quiet because it's better for them if less is going on as opposed to the distraction, making sure that whoever is going to be coming in to do the procedure or whoever else is there is also aware of that. Because coming from the best place, someone could be like, okay, I'm cleaning now. I'm about to do this. And it was a patient who wanted to lean into the distraction. So as you come up with that plan, just making sure it's communicated to everyone, reiterated for the patient, for the parents, for the providers, anything like that, and the caregivers, so that we're on the same page, because that was our plan for a reason. So we want to make sure we're doing our best to go through with it. That doesn't mean plans can't deviate sometimes through that assessment, but that plan and everything we did gives us our best place to start. As we go on, we may have to make some of those changes, but we know when we were not in that super, engaged, worried, excited phase, that this is the plan that we came up with. So we want to include that as best we can when appropriate, knowing that some changes may need to be made though. So one of the things we want to avoid during favorable procedures, kind of goes back to everything else too, is misleading the patient, saying it's almost over if it's not, saying it is done when it's not, and also knowing that sometimes done will mean different for different people. Maybe for someone, done is when what we expect it to be the hardest part is finished and behind us. And for some people, done is when everyone leaves the room because it's all finished. So knowing that, to say it's almost over, it's here when it's not. Imagine you're there, you're taking that next step, someone tells you it's almost over, but then there's a whole other slew of things that have to happen. That comes to the trust, but also just in the moment, if someone's really trying hard to get through something, we want them to actually know what's going on. We also want to avoid invalidating the patient. And this is something that truly comes from the best of places when people do it. But saying things like, you're fine, you're okay, can be really invalidating if you're scared. If you think if you were in a panic state and someone's like, you're fine, you're fine. You're like, no, I'm not. I'm not okay right now. This is hard, but it comes from a great place, but it can be invalidating. That's where we want to come to those helpful phrases like, you're okay, you're safe, you're doing a good job. I'm right here. This is our next step. All of those types of things are really going to help make a difference. So being able to talk about what they're doing well, or what we can do to make things move in a positive direction, as opposed to what can feel like someone brushing off a really big and tough feeling that you have.
Mm-hmm. Best to avoid unnecessary rigidity. So this kind of goes back to that flexibility piece and what Caleb was saying too about, changing the plan or seeing what we can do according to the procedure. So if you think about something like a back dressing change, right? That's very different than a poke setup where you have maybe more options, or it appears that you have more options to ensure a more thorough coping plan for that child. And I think that sometimes for those really hard procedures, we have this mentality of like, well, let's just get through it. It's going to be really stressful for the child at this time, but if we can just get it done quickly, and then we might not have as many detailed coping strategies ahead of time. So so a back dressing change, for example, that child might not have a lot of leeway in terms of positioning, right? They need to be on their side. It's a sterile field. They're not going to be able to see what's going on, so they don't have that option of looking at it. And for some kids, that's really important. They really want to see what's happening during the procedure. So just being really flexible and thinking like, what else can we do for the patient that's in this position, right? So what is in their sight line? Can we ask the caregiver to play something for them, or to squeeze their hand, or, give a lot more control in the sense of having them advocate for breaks. So, we know that you aren't able to see this and that, it's really stressful being in this position and uncomfortable. And we want you to be able to have those breaks as needed. So you let us know if you need a break. And then within that, you can also give options, right? Not every child is going to feel comfortable saying, hey, I need a break. So, even a plan of like, okay, when you squeeze mom's hand, she'll let us know when you need that break. Or when you raise your hand, that means that you need that break. So just ensuring that you're still creating a bit of that coping plan and those strategies for the child, even in those procedures where it may appear a little bit harder to do so.
We wanted to take some time to have comfort holds, comfort positioning kind of be separate from the other ones we're talking about, because it is something that's a little bit different than when we think of distraction, we think of those choices, but it's still something that we want to ensure we're doing in a compassionate way. So one of the things I want to push forward about comfort hold is that we still want to assess for a comfort hold the same way you would for any other coping plan with a child. A comfort hold is a part of a coping plan. It's not the absence of one. So it's not done out of impatience that we just have to get it done. It's out of that assessment that this is what we can do to help that child. So the same as preparation, the same as supporting doing, we can put that in place because not only do we want to make sure that patients are emotionally safe, psychosocially, psychologically safe, we want to make sure that they're physically safe as well. So we want to plan accordingly and appropriately. And it's a big thing, in what we're talking about here is how you're framing things and you're presenting them. It changes how we're going to feel and how we're going to perceive things. So what happens to your arm, to whatever we're doing for the procedure, may be the same, but through that preparation, we're helping shape that encounter as a whole. So that's one of the aspects of pain we're coming across. If someone knows that the job is that we have to stay still for this, so we're going to help you stay still because, when you're scared, it's hard to stay still. You can be scared and safe at the same time. And I want to help this be over because scared is the hardest part. And I want to help you get to finished. You can't be scared of something that's finished. You can be grumpy, you can be upset, and those are fair. But I want to help you through scared. And I want to help you get through this thing because I know you can do it. And saying that help to stay still is something that if you're able to plan with the child, that's something that you can help praise them on as well. We also want to follow up and acknowledge after because there's times when a patient, it wasn't the thing that they wanted to do, but it was important. So giving that chance to follow up, acknowledge that was hard, and here's why we had to do it, and that the child has a chance to ask questions if they're able, and also let us know what they want to share with us. Throughout my interventions with kids, at the start and at the end, it's usually, do you have any questions or things that you want me to know? So in that acknowledgement of the comfort hold, we can help plan who's the best person for that. Is it someone from the team so that a caregiver can be the person they see? Usually when I work with caregivers, it's saying, I want you to be comfort for your child. Is it best if you're the comfort during or you're the hug when it's finished? Because either way, you're here for them and what's going to be the best way for all of you. So I think making sure that it's not done out of, let's get this done, there's nothing else we can do, but actually putting in place as a thoughtful intervention is something that can sometimes go missing because when we think, let's try all of these, and if it doesn't work, we'll do a comfort hold. No, we try these other ones, and if a comfort hold is an aspect of it, let's still do that properly. It goes back to finding the right way to do the tough thing, and we can do those hard things from a compassionate place and what's going to be best for that child. Some of the things that would be best to avoid would be holding parts of a child's body that are unnecessary for the procedure. That also goes even on a smaller bit of if someone looks away from something. Most people look away for procedures, the vast majority, but there are people who need to look. And if you're blocking the way they're looking, it's really going to change. It's going to add that extra stress. So when we come to a comfort hold as the plan, it's because this is what we need to do. So we're only going to do the aspects of it that we need to. Sometimes it's just that hand under your elbow or that hand on top of yours to help you stay still, or sometimes it's that big hug so that we can be fast, safe, and finished. Because sometimes for the right patient in the right scenario, that efficiency can be the kindest thing. We just want to make sure that's done out of assessment, not out of impatience.
Yeah, so just, overall concluding thoughts. So these are really strategies to help minimize, manage, and support children in coping with painful and distressing procedures. We do this in conjunction with pharmacological strategies, not instead of, right? So it's not a fix-all, but I think that psychosocial component is really, really important. And a lot of the literature does show that it has an impact on pain and pain management. So it's important to consider those strategies as well during these procedures for sure. And thank you. There's our emails below, so feel free to contact us with any questions or thoughts. We're happy to be in touch.
Steve, thank you so much for such an awesome presentation. I think I probably speak for everyone on the call to say that like I feel super fortunate to have like an hour of dedicated time where we can hear from you and the experience that you've had. And I really appreciated that you like weaved in some of the more common procedures that frontline staff have to perform at the bedside. And I will always say this, that we need more resources for more child life specialists in the hospital, because the work you do is incredible and so, so important for patients and families. And I feel like we just don't have enough of you guys to go around. But thank you so much for taking the time to speak with us today. We have about 15 minutes or so before the hour's up. So if anyone in attendance has any questions or anything specific they would like to ask of Caleb and Lucy, feel free to put your question in the chat, or even better yet, if you have a microphone and are comfortable unmuting to ask your question, then that would be great. So I'm going to just pause for a couple minutes or a couple seconds, we'll say, and see if anything comes up. And if not, I actually have some questions myself. So I'll just pause for a second and see. A lot of thank yous coming through at people who are very, very appreciative for your time.
Hi, I was wondering if I could ask a question.
Yeah, I can't see who unmuted, but do you mind
introducing
yourself?
Emily.
Hi, Emily, please go ahead.
Hi, I'm a social worker at an early intervention society. So I offer family support for kiddos that are accessing, it's called PUF here in Alberta. So they're aged 3 to 6 with developmental delays or disabilities. And sometimes there's kind of exploration of maybe unexplained pain, or they need to have procedures done. So sometimes I've supported families in attending hospital or kind of navigating that when they're trying to investigate what might be happening for their kiddos. And I was wondering, I guess, because I try to support parents through that experience, and sometimes it can be really scary, and a lot of the children that are attending are non-speaking. And still kind of building those skills on what communication works best for them. It might be pictures or iPads and AAC devices. So that can be difficult too sometimes if not everybody is understanding of those. And I guess, long story long, my question is if parents can request, like if I could recommend to them if they can ask if there's a child life specialist available. Typically they'll be going to Alberta Children's Hospital here in Calgary. Is that something parents are allowed or able to do, to ask, can I get a child life specialist to support in this?
So I can't speak to Alberta, but I can kind of speak to here, and they may work a little differently, but most areas in the hospital would have a child life specialist who's probably covering there. The amount that they cover may change, but probably while booking and letting someone know,
Okay.
as we book, this is hard. I know there are child life specialists at Alberta Children's.
Yeah.
I've just never been there myself, but putting out in general, there's many different ways to get referrals, and that self-referral can be a great way to it. So, the more heads up you would give to the area of the hospital they were giving, the more likely someone can be there at the correct time. But absolutely, we have plenty of families around here who kind of make that request themselves, as well as the teams being able to do that.
Okay, amazing. Thank you. This was really helpful. Thank you so much. I wrote down a lot of just these little strategies that I can maybe offer parents to suggest to a team or do themselves on the way there. I think it'll be really helpful.
Thanks, Emily, for your question. I'm just going to read a comment quickly in the chat from Carrie. So Carrie writes, I attended today as a person who works with people with pain, but as a parent who has had kids have more than their fair share of medical procedures. I think you presented such a beautiful way of minimizing suffering for kids going through a challenging time. Amazing work and great strategies and reminders shared. Thank you. I think that is the sentiment that probably everyone has today.
Thank you. That's so nice. Thanks.
Does anyone else have any questions? Feel free to unmute, or you can also pop your question in the chat.
Hi, it's Shandy. I'm sorry I can't put my my video on at the moment, but I just wanted to thank Caleb and Lucy and all of the people coordinating this for making the time for this discussion to happen. And I really loved how Lucy and Caleb started the conversation and saying, like, we're child life specialists, we're thinking about these all the time. But these are things that we can all do to help support children and families. And I think that's so important. I appreciate that you said we need more child life. I agree. We need more child life. But I also think that every single person can like take these important things that Caleb and Lucy have been talking about and integrate them into with their kids, with their as a healthcare professional as well. So thank you.
8144 background noise. Sandy, I completely agree with you. And I think that's why I was so passionate about hoping to get some child life specialists, and Caleb and Lucy were so kind to agree to today's session. To be able to spread some awareness and spread some knowledge and like tangible takeaways that frontline staff can incorporate into their practice. Because I know I worked bedside for 9 years before I moved on to other positions, and you know, sometimes you just didn't feel equipped to help manage patients. Like, we know what we know, but we don't know what we don't know. And what I do know is that child life specialists have a wealth of knowledge and specialized knowledge that we could all benefit from knowing more about. So yeah, this has been wonderful. I haven't seen any other questions in the chat just yet. There was a question from Caitlin asking if you would be willing to share your slides. And you don't have to answer on the spot. We can talk about that offline. I know for our session yesterday, I think we have a record of all of the email addresses who registered for the event. So for yesterday's event, we're going to share the slides. So Caitlin will let you know, but for Lucy and Caleb to consider if they'd be willing to share their slides. I might just not seeing any questions in the chat. If it's okay, I might ask a question myself quickly. You mentioned actually a decent amount about how to help caregivers support their children through procedures as well. And I wonder, you know, I kind of heard this theme about potentially getting caregivers involved in the procedure, almost giving them a role similar to, you know, the kids can also have a role. I wonder if, like, on top of that, are there any additional strategies that you would use to sort of help caregivers get involved in the care of their child who might be getting a painful or distressing procedure? And then sort of the part B to that is, you know, I've been in situations where caregivers have not felt like they can stay for the procedure. It's too overwhelming for them to see their child in so much distress. And so I wonder, in those situations where a caregiver has sort of placed their boundary and has said, I need to step out for this, there's already people in the room, they will help my child manage, if you've encountered that before and how you navigate those situations.
Yeah, I would say, so I do think that that's why that piece about talking to the parent beforehand is so important. I think that it should be respected. Like, if that parent doesn't want to be present, or it's been really stressful for them before, but that doesn't mean that information can't be shared, right? So including them in that plan, I think, is still really valuable, so that they know, even if they're not there, that this is what's happening with their child in their body. They have a right to know that. And I think sometimes we miss just those like simple check-in questions. You know, we were saying just, it can be really simple, like what has helped or not helped beforehand for you and your child, you know, even just adding that piece, and getting information from them that way, and just having those check-ins. You know, if the clinician is unsure, just saying, are you comfortable, you know, helping out with this comfort hold today? Is that something that you've done in the past? You know, how do you usually find is the most helpful way to help your child through a procedure? So just kind of like explicitly stating those things, I think, is a good strategy. And I don't know, Caleb, if you have anything else to add.
I think even if you have to leave, you can still have a job or a role. I think that job can be to get the blanket for after. It's to get if there was an incentive at the end, or we have to do this before you get lunch, whatever it may be. But that parent could be, their job is to come in at the end as that signifier, and they're the comfort at the end, if that's the best place for them to be. Because I would much rather know a parent is not comfortable and not going to be helpful in the room than find out partway through. So if that parent has that self-awareness to say that, that can still be part of the plan, part of the role, and they can still be involved in a way that suits them best. I think there's been times I've been in a room where a parent finds out partway through they shouldn't be there. And I've even had those where the child is coping fairly well with it. And then the parent's job in that one is, can you take a big deep breath to show Timmy for that breath? because I just need you to take one right now. But so finding out in the middle is one, but also at the end, that doesn't mean that they're not part of the plan, because we can make that plan a little bit bigger and they can still absolutely have a helpful role. You can't be in the room, but here's what we can do to help.
That's awesome and excellent strategies. Thank you both. I think Stacy has said in the chat that Stacy has a question. Stacy, are you able to unmute to ask your question?
I am, yeah, thank you. So I work very closely with Caleb, and I have to say you guys do an amazing job, and as nurses we wouldn't be able to do so many of the things that we're able to accomplish without your help. So thank you all so much. My question is, I work in an outpatient setting, so patients are coming in, often we don't know them ahead of time. They're coming in for procedures or sometimes IV infusions, that sort of thing. And they may come with a lot of anxieties that sometimes we know about beforehand and sometimes we don't. Back, several years ago, there was the pre-op tours and that happened in the hospital, that the kids could come in if they were having planned procedures, that they would have some, like there was a program I think it was run by Child Life, where they kind of introduced what was going to happen during their stay and show them, do some medical play and really prepare them well for the procedures. I don't think that's happening anymore. But my question is, so for those kids that we know ahead of time who have a lot of anxiety about the procedures that they're going for, or have, a lot of needle phobia or anxiety about having IVs put in, is there anything that we can do ahead of their appointment date to try to give them those coping skills and those strategies before the day of their appointments? Because sometimes when it's the day of the procedure, they're already so anxious that it's hard to connect really, really well.
Yeah. I'll take this one, Lucy, as the peri-operative person. With the pre-op program, I think during the pandemic, when we were minimizing people into the hospital and things, that kind of fell down the wayside. And unfortunately, I think we would need some more child life specialists to get that, in place in a more standardized way. But I think it could be an absolutely fantastic thing. I think as far as some of the different units go, it would be worth checking in with the child life specialist that is covering that area. So be able to see what they might be able to offer, whether it's a phone call to the patients or families, it's sending some resources across. Whenever I do something similar, either through blood work or the peri-operative services, it's reaching out to the family ahead of time to see what's going to work. Is it sending a lot of resources or asking you questions or different things? So what may be able to be put in place would depend on the area and going through, but being able to talk to the child life specialist that covers that area and see what can be offered and what might be able to be there. Because every area would be a little bit different, even for capacity for people to come in. Like different hospitals can do the pre-op tours because there's times that the ORs aren't in use. We don't have times that the ORs aren't in use. So we're able to do some prep things, but we're not able to take a tour. So it could be worth checking with the different child life specialists there to see what suits each area best.
Great, thanks, Kayla.
Question, Stacy. I think we're sort of in the last 3 minutes, so I was just gonna mention I put a resource in the chat to just, because Stacy, I think your area sounds quite unique in that you may not necessarily have had a face-to-face interaction with the patient and caregiver before a procedure. And so I wonder if, like, I don't know how the processes work where you work, but like when someone is being booked in for a procedure, for example, if they do receive any information via email or if it's a telephone call, I wonder about whoever makes that first sort of connection with the patient and family, but directing them towards some resources that they could access in order to help their child better manage and prepare them, I guess, for the procedure. So in the chat, I just put in an About Kids Health resource for the CARD system, which is a really fantastic program that was developed, I think, here at SickKids, or certainly it's been adapted here at SickKids. And there's a resource specifically for parents and caregivers. Now, this one is very specific to needle pokes or vaccinations, but a lot of the principles would apply for other types of procedures as well. And then I was just going to throw as well in the chat the resource for the Comfort Promise Learning Hub out of Kids Health as well, which again is probably a bit more needle focused, but again, the principles would apply for pretty much any sort of common medical procedure we may see that could cause some pain or fear or distress. So that's just a starting point. There's actually like a plethora of resources available online through other avenues as well that Stacey, if you want to reach out to me offline, I'm happy to share a few that I've discovered during my time on the cleaning service as well. So in the last 2 minutes, I'm just going to once again say thank you so much, Caleb and Lucy, for taking the time to have the presentation together, but then also for your time today to present this content and being willing to chat with participants and answer a few questions as well. And I think I'll probably leave it at there. And again, more sentiments coming in through the chat. Just thank you and very appreciative of you taking the time to share your knowledge with us today. I hope everybody has a great day. And as I mentioned off the top, we hope that you can join us for some of our other National Pain Awareness Week events that are happening tomorrow. Thank you. Take care.